Hi, I'm Steve Selig, founder of FitTest, and in this short video, as part of a series of videos on aortic stenosis for exercise professionals, in this topic I'm going to talk about the major medical interventions for severe aortic stenosis, namely aortic valve replacement or AVR and transcatheter aortic valve implantation, sometimes called transcatheter aortic valve replacement. So in Australia, it's called TAVI. In the United States, it's called TAVR, TAVR. And also I'm going to cover a case study. So severe aortic stenosis, which is what the topic is for this video. As you can see here, a heavily calcified valve with very little aperture for the blood to be pumped out of the left ventricle into the aortic arch, into the ascending aorta and aortic arch, and therefore around to the body. And so the left ventricle will have to generate a great deal of pressure to get the blood out of this narrow opening into the aorta. And I've, in part one of this series on aortic stenosis, I've given a lot more information on this particular point. So the major medical interventions that are available for severe aortic stenosis, firstly, aortic valve replacement, which the photographs here show very nicely what is happening. Here we have a tissue valve. The tissue valves are generally made out of cow valves or pig valves. And they, surprisingly, when they're all stitched in, they work really nicely, very similar to a native healthy valve in the sense that they open and close passively on pressure differences. So they do produce a good result. There is a small extra gradient, pressure gradient lost across the replacement valve compared to the native valve, but it's very minor and well under minor aortic stenosis, and it is effectively a cure. The challenge, though, for aortic valve replacement is that very elderly and very sick patients, this procedure is a major bit of surgery and often not worth the risk. So fortunately, another procedure has become available, and that's transcatheter aortic valve implantation or replacement. Before I leave this though, generally what I see as an exercise professional is I see the younger patients still undergo this major surgery because some of the clinical outcomes are slightly better with this technique compared to transcatheter aortic valve implantation or replacement, TAVI or TAVR. So I'm going to call it TAVI because that's what it is in Australia. So TAVI is a catheter approach, and as you can see here, a catheter with a balloon inside the replacement valve. So the balloon balloons out the diseased region of the valve, the diseased valve. The diseased valve is not excised, not taken out. It is left in situ, and the replacement valve is placed on the inner lining of this diseased valve, and that valve also works. It's made out of usually made out of animal tissue, as is the replacement valve. Again, this works very well on pressure differential. Now, this technique has really opened up aortic valve replacement, if you like, for the elderly sick patient. So where I see it is usually in people well over 70, even over 80 can have this procedure, whereas they would have been under extreme risk for undergoing the open chest, open heart surgery to have the surgical technique to replace the valve. So this has produced really good outcomes. It relieves the aortic stenosis. These patients do very well, and they're great candidates for exercise after undergoing this procedure. Some patients can have some bridging therapy known as balloon valvuloplasty, which will give the person some symptomatic relief in the sense that it's just the balloon without the valve replacement, such as in TAVI, just the balloon. So the balloon balloons out, stretches out the diseased valve, and in so doing gives the person both physiological and anatomical relief from that aortic stenosis. And this buys time. That's why I called it bridging therapy. A lot of these patients go on to have more stenosis down the track if that's the only intervention that is conducted. But usually this can then be followed up with a TAVI procedure down the track. So this is called balloon valvuloplasty. And so now I'll move on to my client who actually had 2 aortic valve replacements 2 years apart. He was very unlucky. In 2016, he had a aortic valve replacement due to a bicuspid, a congenital bicuspid valve, 2-leaflet valve, and he was implanted with a bovine pericardial trifecta tissue valve. So this was the open chest, open heart surgery, and unfortunately that valve failed, and he then experienced a new aortic stenosis, a new critical aortic stenosis actually, and he was then given a choice to go another tissue valve or a mechanical valve. Because he was very anxious about having another tissue valve, he decided to go with a mechanical valve, which is shown here. So these are also sewn in above the diseased aortic valve, and they're left in situ. So in 2018, very shortly after or around the time of that second valve replacement, he underwent multiple post-op episodes of paroxysmal atrial fibrillation, both in hospital while he was still in hospital and at home. But more worryingly, about 6-7 months later, he collapsed at home and was pulseless for 10 seconds. Fortunately, his wife is a nurse and was able to resuscitate him, but he did actually wake up spontaneously, and he was then fitted with a loop recorder, which was effectively a remote monitoring event recorder. And this was monitored remotely 24/7. And you can see here the rhythm. This is not the actual rhythm, but it's very much like the rhythm he had when he was pulseless. You can see here the P waves that I'm pointing to here. And there's a P wave there, P wave, there's a P wave here, P wave. So the P waves are undergoing their own rhythm, completely separate and faster than the ventricular rhythm. There's only 3 beats here for about 7 or 8 seconds of rhythm strip. So this heart rate is well under 30. It's probably about 20 to 25 heart rate here. And that's why he collapsed and fainted at home. And this pulse was very weak. In fact, it was pulseless. And so that's what happened. He was lucky in the sense that this resolved with time. It was just an episode, and he didn't have to go on to have a pacemaker. But ordinarily, I mean, this is complete AV nodal block, and ordinarily these patients would go on and have a pacemaker fitted. But in this case, it was deemed not necessary. He still has the loop recorder that is monitored 24/7. So if this or some other dangerous bradyarrhythmia arises, he'll undoubtedly be fitted with a pacemaker and maybe even a defibrillator. So I saw him after the first valve replacement in 2016, and I've just recently seen this patient again. So I'm just reporting here using my fit test app the 2 exercise tests. This is 2016. I actually didn't have my fit test app at that time, but I've just transferred it to my fit test app to compare the data. And at 180 watts, which is what he achieved in 2016, his estimated VO2 peak was 37.2, and heart rate peak on metoprolol was only 83% of predicted, whereas more recently in 2020, his heart rate was higher at 150 and percent predicted was 96%. And it just shows you that the fit test is able to adapt beautifully to these changes in peak heart rates, and in fact the changes in all of the heart rates, and make adjustments for that. I mean, that's what the app is, one of the strong features of the app. So let's now look at what the graph shows. I've just done the 2020 test here, and he's got a number of workloads with a very high linear correlation. So these are his actual heart rates here up to VO2 peak. And the VO2 peak, even though he's had 2 aortic valve replacements now in 2016 and 18, he's still doing pretty well on the bike. He's only 65 kilograms, I think, and he rides at 180 watts, which is a pretty decent workload for a 75-year-old after 2 aortic valve replacements. So Fit Test has been able to cope with this beautifully, and I suggest you just have a try, and you can put in dummy data or real data, and you'll hopefully have as good experience as I had with this client. So thank you. That's all I wanted to share with you on this video. You can contact me at info@myfittest.com.au. Thanks and have a great day.